Hello everyone, I'm Megan O'Brien from the Social Work Department at St Vincent's Hospital. I'm here to present and talk to you about some of the strategies or things that you might want to consider when you're delivering this module in relation to family violence and older people. So this is a module that's been designed by the Social Work Department at St Vincent's, and some of this work has been built on what we've been developing within our own organisation and learnings from our clinical work and governance in relation to elder abuse over the last 10 years. So the assumption really is for staff who are undertaking this module that they have participated in Module 1 and Module 2 and have understanding really about the principles of sensitive practice in relation to the Strengthening Hospitals Response to Family Violence project. So in terms of the session outline, these would be some of the things I think you really need to make sure that staff are aware of. Obviously all of these slides do have accompanying notes that will support you in terms of the delivery of this module, but I suppose the key thing really to outline here when you're teaching or working with staff in relation to elder abuse is really making sure that staff know what they're doing and are confident in knowing how to respond if older people do disclose, or if the triggers or signs are actually there for older people in relation to elder abuse. This slide really about why we should be strengthening our response to elder abuse within each organisation. This is a slide I would be suggesting to you that you really probably need to give a little bit of time to, and the reason I'm saying that is because of the unique nature of elder abuse. I think it's important that we recognise that this module is around family violence across the lifespan, but elder abuse is unique, and how health professionals do respond needs to be actually considered. So obviously the points around the fact that health services have to respond, part of Statement of Priorities, is all important, but certainly what we know from the Royal Commission is that hospitals are in a unique position in terms of supporting older people who may be at risk or experiencing elder abuse. And more importantly, what we know from the Royal Commission is that elder abuse is underreported. So it's an emerging issue, and health professionals are in a unique position to support older people. What I'd suggest you do also is perhaps get an understanding, talk to your clinical coders or data people within your own organisation, because I think this is always helpful to actually have an understanding of your presentations of your older population coming to hospital. For example, at St Vincent's, we know just over 50% of our patients who are admitted to our hospital are aged over 65. So actually having some understanding about the demographics of that, and really honing in terms of understanding that the ageing population, the baby boomers, all of this does have an impact on terms of the complexity and what we're actually seeing in our health services. So I just think it's important to actually spend a little bit of time really explaining the unique nature of older people and how they interface with our hospital system. In terms of this slide, again, I think the key message really is here is to confirm that family violence does now incorporate and is associated with elder abuse, and we know that from the Royal Commission. But again, it's really about highlighting that elder abuse is unique, and how we respond to health professionals should be different to other forms of family violence. There really is the notion there that elder abuse absolutely is this violation of human rights, particularly for older people. So the definition in itself now is inclusive of elder abuse. So I think it's important to really stress that particular point in this slide. This slide, which really talks about the actual definition of elder abuse, this is the World Health Organization. This is the definition that's probably most widely used and is accepted here in Victoria in terms of our response as health professionals to elder abuse. And the key messages really here are to stress that elder abuse is this notion of trust. So elder abuse is where a trusted individual, usually a family member, is perpetuating or causing abuse or harm to an older person. What's probably not outlined enough in this module is the fact that elder abuse is really associated with family members, and what we know from the literature or research is that 90% of elder abuse is caused by a family member, usually a son or daughter. So that in itself is quite different in terms of other forms of family violence, and usually some of these family members can actually be people caring for their elder relative or something like that. So there's that element of trust and relationship in terms of the definition. It's also important to actually touch on what is not included in the definition of elder abuse. So sometimes in this particular scenario, I will talk about scenarios such as where an older person might have an experience of fraud, or someone might be taking advantage of them in relation to some sort of transaction or something like that. So perhaps using examples like that, but it's important to actually also outline what is not included in the definition. In terms of the myths about elder abuse, again, part of this slide will be you talking to your audience around getting them to think about the myths, getting them to actually consider what elder abuse means to them. Probably some of the key messages really here is to touch on the uniqueness about elder abuse, that both men and women are affected by elder abuse, and certainly men can experience abuse from sons. So for example, that is quite unique in terms of what we actually see, and which makes elder abuse quite complex in terms of how we work with family members, and particularly older people, because of their trusted relationship within family. And what we also know is that older people, it's quite apparent that the concept about elder abuse is really about understanding the construct around older people being marginalised and discriminated against. And if you do have more time to actually do some training to perhaps social work staff or other key staff, I think understanding the construct about ageism and how health professionals undervalue older people within our society, and that really perpetuates how we actually work with older people. And we do see ageism a lot within a health setting, and we need to be important that we actually consider that. So it's really important to actually perhaps have an understanding about ageism as well. In terms of the types of elder abuse, you may want to certainly refer to, with respect to age, which is the current Victorian government document that certainly gives some more information about the types of abuse. But these are the main 6 types of abuse that are actually recognised here in Victoria. And it's really important that as health professionals, we really know what to look for in relation to elder abuse. And quite importantly, the thing I'd be stressing here is that what we know from the literature, from some of the research that's actually been happening, it's very common for older people to be experiencing more than one type of abuse at any one time. So certainly in our health service, we've seen a number of our older people who are experiencing at least 2 or 3 types of abuse. So for that reason, it's important to actually have an understanding of the different types of elder abuse and how they interface with each other. In terms of noticing the signs, what we know about elder abuse is the experience of family violence can look different for older people. And certainly the language that I use, and you may want to choose whatever language is most fits your organisation, but also talk about sort of red flags or triggers. So these are types of things that health professionals can actually look for when they think something might be actually happening in terms of an interface between an older person and their family member. So, for example, you may notice behaviours for an older person. They might be feeling unhappy or isolated, missing appointments, or appearing vague in responding to questions. And also you might actually even see signs within a potential perpetrator or family member. So they might minimise or deny the abuse, blame the older person, be present in all interviews, and they may even, for example, answer for the older person. So they may actually not let the older person speak for themselves. So all of those are signs to actually look for, and it's important that we actually talking and teaching health professionals about some of those signs. So you might actually ask the audience to also think of some signs or things that they may have seen within their population as well. So again, it's really important that just because these signs are actually existing, it doesn't mean that elder abuse is occurring. It just means as health professionals that we can be mindful of that. And it's quite likely that if you see a number of signs or observe a number of behaviours within a situation, it is quite possible that there might be elder abuse actually occurring within that particular situation. This is a case study that I've included for the purpose of the module, and really the idea of this case study was really to get staff or health professionals to think about what might be the signs or behaviours in this particular scenario. What I'd suggest you do, and it certainly works best when I'm presenting to different programs or teams, to actually use a case study that might mean something to that particular group. So you may actually want to think about changing this case study for the particular audience. If you're dealing with staff in a community setting, you might want to change the scenario, vice versa in terms of if you're working with staff in an inpatient setting. So think about the scenario, what you might use in your particular module, but it's really important about trying to get staff to actually think about those indicators that that they might pick up on in a particular scenario, and more importantly, what they will actually do in terms of starting that conversation with that older person. So the next 6 slides are really a breakdown of the different types of elder abuse that are actually considered as part of this module. Again, these slides really are just some indicators, which include both signs and behaviours. It's about teaching staff to think about some of those types of things. What I've actually done within St Vincent's is actually developed a pathway or a 1-page laminated form. So some of the information that includes the signs and behaviours are actually included in that. So they've actually got that in front of them, which actually includes some of this information. But it's also, you might actually even want to think about just explaining very briefly what each of these actually mean in terms of the definition. So for example, physical abuse really involves the infliction of physical pain or injury. And then you can actually talk about some of the signs or behaviours to look for. What we know about financial abuse, it's the illegal or improper use of an older person's assets, which can include both property and finances. What we know about financial abuse, it is probably the most common form of elder abuse that we actually see within a health setting. And studies certainly do suggest that as people age, experience of violence really shifts from physical and sexual to more emotional and financial abuse. So it is quite possible that financial abuse is probably the most common thing that you may see with an older person, but also appreciating that they might be experiencing financial abuse, psychological abuse, and some other form of abuse actually happening at the same time. So in terms of psychological abuse, what we know is that this is the infliction of mental stress, fear, feelings of shame or powerlessness. So again, these are some of the behaviours that you might see with an older person. Again, getting the staff in the audience to perhaps think about this, whether they've actually worked with any older people that they might have seen or observed some of these behaviours. Sexual abuse, certainly in our health service, we haven't seen, or older people haven't disclosed it. That's not to say it's not existing, but it's certainly not something that is evident in terms of the research that's actually happened in relation to older people. But as we know, sexual abuse describes a range of sexual acts where the older person does not consent to what's actually happening. And I would certainly suggest if sexual abuse is something that your staff want to know more about, or that you do see it within the cohort of patients that you're actually working with, I would strongly encourage the staff to actually be part of the specialist module in terms of sexual assault. And certainly that the sexual assault module does incorporate, and there's certainly skills there to help staff, particularly for older people as well. In terms of neglect, what we know about neglect is that neglect can be intentional or unintentional. And there's certainly situations of carer stress, for example, where you'll see that some carers may believe that they're actually doing something that they generally believe is in the best interest of that older person, but it's actually might be placing them at risk, or it might be a decision that we as health professionals don't necessarily support. But it's important to actually understand that neglect can be there can be forms of neglect that can be unintentional, and it's also important at this particular point to stress as part of the training that self-neglect by an older person is not included in the definition of elder abuse. So as we know, there are some older people who may choose to make decisions about how they live, or in terms of a certain lifestyle that may place them at risk, or may have impacts in terms of their health and well-being. But if an older person has capacity to make their own decisions and they make choices around self-neglect, that's actually not considered a form of elder abuse. In terms of social, this is the last type of elder abuse that's included in this model, and really what we need to understand about social abuse is when family members or people in a trusted relationship will make decisions that will really put limitations on an older person in terms of access to their community or their friendship groups or something like that. So again, you might get people to start thinking about some of the examples, or with they've worked with older people where some of these behaviours or signs might be present. It's really important then when a health professional does observe some of these signs or behaviours that they really think about what their next course of action will be. And it's suggested that health professionals really do follow a cascading series of questions from more general to more specific, and really about monitoring the older person's comfort during that conversation. So it's important to really build trust with an older person if you suspect elder abuse. And certainly what our experience at St Vincent's is, even if the signs are there, even if you are concerned that an older person might be at risk, they may not be ready to disclose or confirm that abuse might be actually happening to them. So it might be after a number of presentations to hospital, it might be after a number of visits, or as they're building trust with a health professional, they may then choose to disclose. So it is quite important that it's about building that trust and making an older person feel safe before you'll actually start asking these questions. In terms of responding respectfully, and this is where we really start thinking about the principles in terms of how we might start working with an older person in relation to suspected elder abuse, and really disclosures of elder abuse really need to be heard and acknowledged, and health professionals need to be non-judgmental in terms of how they respond to older people. And it's really important to remember that the patient is their expert in their own story, and that really applies to older people as well. Just because someone is 85 or 90 doesn't necessarily mean that we do not we should be valuing their story and valuing their contribution. And if they're actually talking to you about their fears or their concerns, that we need to validate what they're actually talking to us about and actually listen to their story. And really about treating older people with dignity and respect. So we need to appreciate that some of these older people might be disclosing abuse for the first time as an older person, and they may be actually experiencing intimate partner violence or another form of family violence for decades, and they might be disclosing for the first time as an older person. So it's really important that first response is really about supporting them in terms of making those decisions. So thinking about starting with more open questions is what the key thing you really need to be talking to health professionals about in terms of this training. So talking about, how are things going for them at home, how do they spend their days, and then as you build trust and as you feel more comfortable in terms of getting a sense where that older person might be at, then ask more direct questions if you believe that abuse is quite strong in terms of your suspicion. So then asking more direct questions such as, are you afraid of anyone at home? Has anyone shouted at you? And really, with older people and elder abuse, principally it's around supporting that older person, plus balancing that in terms of ensuring that their safety is maintained, and also about making sure that you empower them to make decisions around their own life and giving them information to make informed choices. So privacy is really important in terms of when you're working with an older person. Talk to the older person alone. And the other thing really when you're thinking about working with older people around family violence is really having an understanding whether that older person may have any sensory deficits that you need to consider in terms of your conversation. Really avoid any speech or any suggestions of any ageist comments, or don't be patronising when you're actually speaking with older people. So, and lastly, be really culturally sensitive. So make sure you use interpreters, don't use jargon, and really think about the information you're actually providing to that older person. So it might be that if you need to give them information and resources, if you use an interpreter, then think about perhaps giving them that information in the language that they can perhaps go away and take that material and then perhaps reflect on that and read that. So that starting point in terms of responding respectfully, there are some key points to actually really stress when you're actually working with older people. In terms of elder abuse risk factors, again, one thing I'd be suggesting when you're actually talking to risk factors is just be mindful of the language within your own organisation. So The language that certainly is still used quite consistently in relation to family violence is victim or perpetrator. In our health service, we talk about the older person, and we also talk about the person of concern or the person of trust. So when you're delivering this particular slide around the risk factors, you may want to use the language that's consistent within your own organisation. And it really is important to understand that there's both risk factors for the older person and also the alleged perpetrator. So having an understanding of those risk factors is important, because what our role is as health professionals is to see what we can do about minimising those risks and about supporting that older person to make decisions. And in situations where family members are providing care to that older person, it's about trying to think about what else we can do to minimise that risk, what supports we can put in place, what can we actually do as health professionals to support that older person to make them feel safe. So identifying risk in relation to elder abuse really does require the workers to balance carefully the autonomy of the older person and the person's identified and assessed risk. And I can't underscore enough the complexity, I think, with elder abuse, particularly when you're working with older people and there might be cognitive impairment, there might be issues around dementia, there might be mental health issues, and there might be issues in relation to them having a disability, which really does impact on how we as health professionals actually work with that older person to ensure that we're actually supporting them in terms of their decisions. So certainly in modules 1 and module 2, there is quite a lot of information in relation to the health impacts, particularly on women and children in relation to family violence. There's not as much strong evidence or research really around the health impacts of elder abuse on older people. What we do know though is that older people who are subject to elder abuse do face a greater risk of hospitalisation, and what we also know is that older people that do experience elder abuse have significant impacts in terms of their emotional and psychological well-being. So we know from a number of research or studies that elder abuse is associated with depression and anxiety. So what we certainly see in terms of elder abuse is probably more the psychological impact on older people. And certainly within our health service, what we are aware of is that older people do not present to hospitals because they are at risk or experiencing elder abuse. What normally would happen, as we know, is that older people do have a significant interface with the hospital system, and it's usually during their hospital admission for another unrelated medical issue that they will disclose or they will talk to a health professional around elder abuse. So it goes back again to the unique position that health professionals actually have in terms of supporting older people within a in a hospital setting. In terms of barriers to disclosure, what we also know about family violence is that elder abuse in itself is hidden, and we also know that elder abuse is underreported, and it's underreported by both health professionals and older people. So it's important in this particular slide to really have an understanding why older people might be fearful, why is it that they're actually not feeling confident or comfortable to speak to health professionals. So I would spend a little bit of time really going through these barriers and really getting staff to actually focus on some of these barriers and actually have an understanding from the older person's point of view what it means to them in relation to a family member who might actually be causing that abuse or harm to their particular person. So that concept around parental love and responsibility, I think, as social workers within a hospital setting, we're very mindful, particularly mothers who may be widowed, who have taken on caring responsibility for children who may never have left home, for example. And it's really about that they will continue to support them and justify, and sometimes they don't necessarily recognise that what's actually happening to them is a form of elder abuse. So it's important to actually focus on some of those barriers in relation to disclosure. So this slide really is an opportunity as the facilitator to get a sense from your audience in terms of what are the barriers for staff. So what are the barriers for health professionals in relation to responding to elder abuse? What I would certainly suggest here is that it's important in terms of some of the barriers that has really come out from the work I've been doing in this area is some of the barriers really talk about that staff are not confident to know what the pathways are, what the policies are, what the guidelines are, who do they talk to, what do they do with the information. So this would really be a key point where if you have a hospital policy, either around family violence or if you do have one around elder abuse, to use examples from that policy in this particular slide to provide confidence to staff in terms of how they're actually responding. In terms of the cultural considerations, these are just three groups of patients that we've touched on in relation to this module, and certainly some of this information is available in the other modules. But again, you might want to think about your audience. Who is your population of patients within your health service? Certainly in our health service we have a high population of patients who present to our particular health service from a cold background, and we do have a high rate of notifications of older people from a cold background who are at risk of elder abuse. So you might want to consider the cultural considerations, and I think it's really important here to stress that elder abuse can mean different things to different cultures, and no one size fits all for the different communities. So be mindful of that in terms of when you're talking to your particular audience, and again refer back to your policies in relation to this. And you might even want to think about, if you do have a hospital liaison officer, an Aboriginal liaison officer or something like that, think about engaging them in terms of this particular part of the module as well. In terms of the action plan, it's really important at this particular point to really stress to your audience that they need to think about who in their organisation is going to have the responsibility to support that person. So if a health professional has identified that an older person might be a risk, they might have started the conversation and followed some of those principles around sensitive practice. If a detailed assessment or a comprehensive care plan needs to be undertaken, it's important at this point that staff are familiar with who does have that responsibility in the particular organisation in terms of facilitating the action plan. So it really is about determining the level and urgency of the situation, and the response by health professionals will really be dependent on the safety of the older person. So again, be mindful that if an older person does have capacity, they might be experiencing elder abuse but they don't want help, we need to respect that. So at this particular point you might even want to think about including some information and supporting staff around duty of care principles and weighing up some of their roles and responsibilities in particular to their organisation and how they might be responding to elder abuse. And you might also want to consider the role of the multidisciplinary team and how you might use colleagues and other departments or teams within your organisation in terms of supporting that older person. And really remembering the family inclusive approach. What we particularly know about older people is that it is likely that in many situations that older person does want to maintain that relationship with their family member who might be causing the abuse or harm to them. So thinking about family inclusive practice and how we can actually support both the older person and the family if elder abuse is actually suspected. So in terms of the domains of assessment, these are some domains that you might want to think about. So if a health professional has got to a point where it is very likely that an older person might be experiencing or at risk of elder abuse, these would be some of the domains that I would think about. This is not, and you might actually, this is not critical in terms of what you need to think about, but again, it might be possible that in your particular guidelines or protocol within your organisation that you might have a model of care or steps for staff to actually consider in relation to the actual assessment itself. So we've touched on the risk assessment, and that's really about the urgency and the risk to the older person. So if an older person does present to the emergency department, if the older person is an inpatient and they might disclose to someone that they're frightened of going home, for example. We had a case in our rehab ward where there was an older woman who'd been experiencing decades of intimate partner violence and she had never disclosed to anyone. It was only at the time of her discharge where she felt more vulnerable or concerned that she actually disclosed to the social worker on the ward, and that was because she was actually going to be sent home with a frame. So the fact that she was being sent home on a frame meant that she felt that she couldn't stand up to her husband and was quite fearful about actually returning home. So the risk assessment is really about what the context is in terms of where that older person might be, And it might be that if health professionals are actually going into the older person's home, that the risk assessment for that older person is going to be different to an inpatient setting, for example. So some of the other domains to think about is really the general appearance of the older person. I would really encourage staff that they really need to think about doing, obviously importantly, interviewing the older person, interviewing the family, other sources, and the GP, for example. So it might be possible in some situations where there might be situations of really quite profound carer stress, and it might be that a family member has taken on a caring role. They may have given up full-time work, for example, and their older relative might have quite advanced dementia or something like that. So it's quite possible in some situations that you might see situations of profound carer stress, and it's important in those situations, by doing thorough interviews of the family, of GPs, or if there's service providers involved, actually doing getting a picture of what's actually happening, because it's about minimising that risk, and it might be about putting services in can actually reduce or minimise that particular scenario in terms of that risk for that older person, and more importantly providing that family member who might need the support in particular in relation to that caring situation. In some situations you'll need to perhaps consult with medical staff around physical examinations. It's important to work with other allied health colleagues in terms of working with older people. Functionally, what we know is one of the highest risk factors for an older person who makes them more vulnerable is around dependency for an older person. Their cognitive assessment, so really having an understanding about their capacity, and really having an understanding about what the triggers are to indicate a need for a capacity assessment. So, you know, it might be that an older person repeatedly making decisions that's placing them at risk. We had a patient in our health service who presented 18 times over a 12-month period to the emergency department quite late at night, because they were quite fearful of what was actually happening at home. But that was an older person who actually had capacity, and they chose each time to return to that particular situation. So in some situations, it is important to actually have an understanding about the capacity of the older person. So some of the other triggers might be, you might be noticing problems with memory, displaying behaviours out of character. So in those situations, it's really at that point that you would actually consider to actually undertake a capacity assessment. The next slide is really about the empowerment approach in terms of how we consider elder abuse. And what I'd really be stressing in terms of the training in relation to this particular slide is having the understanding that in Victoria we have an empowerment approach in terms of how we support older people. There are 7 principles, and again I would suggest that if staff want to know more about this to refer to With Respect to Age document. But it's also important to, at this particular point, to have, perhaps you might have questions staff might ask around mandatory reporting of elder abuse, and you might actually need to actually have an understanding to be able to answer the questions around mandatory reporting. So in summary, there is no mandatory reporting of elder abuse unless it's sexual or physical assault within a residential care facility. So it's not an approach that is widely supported, because certainly the empowerment approach is how we as health professionals should support older people. So in terms of the next slide, again, I would be really thinking about how you can tailor this slide in your module to your own health service. But there are key agencies that would be supportive to health professionals in relation to elder abuse: Senior Rights Victoria, Office of the Public Advocate. Certainly my experience in our health service is it's unlikely that older people may choose or are interested in going down the pathway of general family violence services. But again, this is where you might need to be really thinking about what internal services you've got, whether it's transition care, for example, whether it's your HARP or HIP programs, that you can consider in terms of supporting older people who might be being discharged from the health service. So certainly adapt this slide to your own organisation. And again, documentation, again, I would really focus on documentation which is paramount to your own organisation. If you do have a policy within your organisation, I would certainly pull out key parts of that, and just be mindful that documentation is particularly important in relation to any form of family violence, because you will have patients who are moving through the hospital system. If you have medical records on file, paper records, what we know is that different programs have access to different databases, so it's important that there are systems in place to support staff in relation to documentation, and more importantly, thinking about making sure that the older person doesn't continually repeat their story and duplicate their story in terms of health professionals. So that's certainly some of the considerations around documentation and elder abuse. Again, this is really just a slide which provides a summary in terms of thinking about sensitive practice in relation to elder abuse. Probably one of the main key things I want to really highlight here is one of the key recommendations that came out of the Royal Commission in terms of supporting older people is about supporting that older person to remain in their own home. So one of the strategies as health professionals is it shouldn't be a quick fix in terms of removing that older person from their own home, in terms of making them feel safe. It's about working with that older person to empower them and supporting them to remain in their own home, and offering them choices or options in terms of decisions to be made in particular to their situation. And really the key messages for elder abuse is, I think the key message really that I would like you to talk to your staff about when you're delivering this module is really to, I suppose, expand on the fact that elder abuse absolutely is a recognised form of family violence, but it is unique in terms of how we as health professionals respond, and it's about really being sensitive to older people in terms of their choices, and particularly following the principles of the empowerment approach that is so well supported within Victoria in terms of how we as health professionals respond to older abuse. And really the last slide is really just an opportunity for you as the facilitator to talk to the health professionals that you're training, really to get some sense from them in terms of whether this module itself has supported them in terms of having an understanding about elder abuse, and more importantly, getting them to reflect on how they might work with an older person differently, particularly in scenarios where they might suspect elder abuse might be happening. So thank you very much.